Welcome to Med Made Simple. Today we are diving into a real medical mystery. In this explainer, we're unpacking a fascinating condition called Takayasu Arteritis. We'll be using some absolutely excellent source material from Osmosis by Elsevier to figure out exactly how this disease operates step by step.
So think about this bizarre clinical question for a second. What actually causes a patient's pulse to just vanish? It sounds like something straight out of a medical thriller, right? But this physiological anomaly is actually the defining characteristic of Takayasu Arteritis. In fact, it's exactly what gives this rare condition its rather intimidating nickname, the Pulseless disease.
To crack this case, we first need to define the culprit. Takayasu Arteritis is a rare inflammatory disease, and it specifically targets the body's largest highways, the large arteries. We're talking primarily about the aorta and its major branches. So things like the carotid arteries, which supply blood to the head and neck, and the subclavian arteries, which feed the arms. And the root cause? Well, it's an autoimmune process. Basically, the body's immune cells get confused and mistakenly launch a full-on attack against the walls of its very own blood vessels. Now, age is always a massive clue in the world of diagnostics. And for Takayasu Arteritis, the magic number here is 40. A key hallmark of this condition is that the onset of the disease almost always begins before a patient reaches 40 years of age.
Put that age factor together with a few other demographics, and a very specific clinical profile emerges. This condition predominantly affects young females, especially those of Asian descent. So when you combine these factors, young, female, of Asian descent, and under 40, you've got your very first, and honestly perhaps most vital, diagnostic clue to guide your thinking. All right, let's move into Section 1, inside the arteries, the scene of the crime.
This is where things get really paradoxical. The chronic inflammation in these arteries creates a bizarre twofold problem. On one hand, it replaces the natural elastic fibers and smooth muscle cells with this rigid scar tissue. This causes the vessel walls to thicken up massively, which gradually narrows the space for blood to flow and leads to occlusion. But on the other hand, despite being thicker, the walls actually become structurally weaker. They've lost their natural elasticity, so they can't stretch and recoil properly anymore. And this loss of flexibility makes those affected arteries highly prone to balloon-like bulges, aneurysms, which, as we know, carry a severe risk of rupture.
Okay, Section 2. Clues in the body, systemic and localized.
At first, the clues are just frustratingly vague. Early on, the condition masquerades as an everyday illness with generic systemic symptoms. Patients often present with a fever, some unexplained weight loss, night sweats, a general sense of malaise, and just deep, profound fatigue. At this early stage, it's incredibly difficult to pinpoint Takayasu Arteritis because, let's face it, these signs overlap with countless other routine infections.
But as the disease progresses and blood flow becomes severely restricted, the clinical picture really sharpens up. We can literally map the symptoms right onto the geography of the body. For example, if the inflammation hits the subclavian branches serving the arms, that's where you get that famous weak or totally non-existent pulse. You might also notice a blood pressure difference between the arms of more than 10 millimeters of mercury, whooshing sounds or bruits over the arteries, and claudication, which is muscle pain that flares up with activity. Now, if it strikes the carotid arteries feeding the head and neck, patients might experience visual disturbances, headaches, dizziness, fainting, or even strokes. And if it involves the lower aorta, specifically the renal arteries, it triggers systemic high blood pressure. So the symptoms are essentially red flags telling you exactly which vital pipes are blocked.
Moving on to Section 3, catching the culprit, diagnosis.
So how do we confirm it? We start the investigation with lab tests, searching specifically for elevated pro-inflammatory markers. We're looking at things like the erythrocyte sedimentation rate, or ESR, and C-reactive protein, CRP. But the real slam-dunk confirmation comes from advanced imaging. Getting an MRI or a CT angiogram is absolutely essential here, because the damaged segments of these vessels often alternate with totally normal-appearing ones. Imaging the entire aorta and its branches is heavily recommended. You literally have to look at the whole system to avoid missing those alternating areas of thickening, narrowing, or any hidden aneurysms.
Now here's a really surprising medical twist. If you study vasculitis, you know a tissue biopsy is usually the gold standard for getting a final diagnosis. But with Takayasu, unlike a lot of other inflammatory conditions, you usually do not need to perform a biopsy to crack the case. The combination of the clinical signs, the elevated blood markers, and that comprehensive imaging we just talked about is totally sufficient to confirm it.
Finally, Section 4,
treatment and management, restoring the peace.
We basically launch a stepwise counterattack against the inflammation. Step 1. We start heavy. High doses of corticosteroids are used right off the bat to rapidly suppress the inflammation and just halt the disease in its tracks. Step 2. Obviously, we can't keep patients on high-dose steroids forever, so we gradually taper them down. At the same time, we introduce additional immunosuppressive agents, like methotrexate, to maintain that control. And step 3, for those really challenging cases that are refractory or just keep relapsing despite the standard meds, we deploy advanced biological treatments. This means bringing in TNF inhibitors like infliximab or adalimumab to specifically target those stubborn inflammatory pathways.
The harsh reality is, the course of Takayasu arteritis is highly prone to relapsing. These patients are in it for the long game. Long-term immunosuppressive therapy is generally necessary. There is no quick fix here. It requires a super vigilant, ongoing management strategy to keep the disease suppressed and protect those vital large vessels from irreversible structural damage over the course of the patient's lifetime.
To wrap up this explainer, I want to leave you with a thought to spark your curiosity about the broader implications of this. If we can master the paradoxical thickening and weakening of arteries in Takayasu arteritis, if we can figure out how to teach the immune system to stop attacking its own largest highways, what other complex autoimmune mysteries could we unlock next? The insights gained from solving the pulseless disease could very well be the key to the next great medical breakthrough.